Pleural effusion. Introduction. Normally, the pleural space contains a small amount of fluid, 5 to 15 ml, which acts as a lubricant that allows the pleural surfaces to move without friction. But if fluid builds up from either increased production or inadequate removal, pleural effusion results. Pleural effusion, bilateral or unilateral, parapneumonic process. Pleural effusion refers to any significant collection of fluid within pleural space. Any imbalance in formation, absorption lead accumulation of pleural fluid. Definition. A pleural effusion describes an excess of fluid in the pleural cavity, usually resulting from an imbalance in the normal rate of pleural fluid production or absorption, or both. Pleural effusion is a condition refers to a collection of fluid in the pleural space. It is almost secondary to other conditions. The excessive amounts of such fluid can impair breathing by limiting the expansion of the lungs during respiration. Types of pleural effusion. Transudative effusions. Exudative effusions. 1. Transudative effusions. Transudative effusions, also known as hydrothoraces, occur primarily in non-inflammatory conditions, is an accumulation of low protein, low cell count fluid. Causes. Increase hydrostatic pressure found in heart failure, most common cause of pleural effusion. Decrease oncotic pressure, from hypoalbuminemia, found in cirrhosis of liver or renal disease. In this condition, fluid movement is facilitated out of the capillaries and into the pleural space. Characteristics of transudative effusion. Low protein, low cell count fluid. Clear to faint yellow tinge, no odor. pH 7.40 to 7.55. Specific gravity, 1.015. Protein content, 3g 100 ml. Glucose level equal serum plasma. 2. Exudative effusions. Exudative effusions occur in an area of inflammation, is an accumulation of high protein fluid. An exudative effusion results from increased capillary permeability characteristic of inflammatory reaction. This type of effusion occurs secondary to conditions such as pulmonary malignancies, pulmonary infections and pulmonary embolization. Causes. Disseminated cancer, particularly lung and breast, lymphoma. Pleuropulmonary infections, pneumonia. Heart failure, cirrhosis, nephrotic syndrome. Other conditions: sarcoidosis, systemic lupus erythematosus, SLE. Peritoneal dialysis. Characteristics of exudative effusion. Often turbid, bloody or purulent. pH 7.30. Specific gravity 1.016. Protein content 3g 100 ml. Glucose level 60 mgdl. High protein fluid. Types of fluids accumulated in PE. There are mainly 4 types of fluids can accumulate in the pleural space. Serous fluid, hydrothorax. A hydrothorax is a condition that results from serous fluid accumulating in the pleural cavity. Blood, hemothorax is a condition that results from blood accumulating in the pleural cavity. Pus, pyothorax or empyema is an accumulation of pus in the pleural cavity. Chyle, chylothorax. Chyle is a milky bodily fluid consisting of lymph and emulsified fats, or free fatty acids, FFAs, and it is formed in the small intestine during digestion of fatty foods. It is a type of pleural effusion. It results from lymphatic fluid, chyle, accumulating in the pleural cavity. Pathophysiology. Transudative pleural effusions. Exudative effusions. Clinical manifestations. The clinical presentation of pleural effusion depends on the amount of fluid present and the underlying cause. Many patients have no symptoms at the time a pleural effusion is discovered. Pleuritic chest pain. Dyspnea. Non-productive cough. The chest pain is usually sharp and is exacerbated by movement of the pleural surfaces, as with deep inspiration, coughing, and sneezing. Assessment and diagnosis. History collection, a history of pneumonia, PTB, chest tumor, cardiac, renal, or liver impairment and cancer-related treatment. Physical examination, decreased or absent breath sounds, decreased fremitus, and a dull, flat sound when percussed. Chest X-ray. The posterior and lateral chest radiographs are still the most important initial tools in diagnosing a pleural effusion. Ultrasound is useful both as a diagnostic tool and as an aid in performing thoracentesis. It assists in identifying pleural fluid loculations. Computed tomography, cross-sectional computed tomography, CT. It helps distinguish anatomic compartments more clearly. This modality is useful as well in distinguishing empyema. Thoracentesis, also known as thoracentesis, pleural tap, needle thoracostomy, or needle decompression, is an invasive medical procedure to remove fluid or air from the pleural space for diagnostic or therapeutic purposes. Medical management. The objectives of treatment are to discover the underlying cause, to prevent reaccumulation of fluid, and to relieve discomfort, dyspnea, and respiratory compromise, maintaining oxygenation and facilitating drainage. Therapeutic thoracentesis may be done if the fluid collection is large and causing chest pressure, shortness of breath, or other breathing problems, such as low oxygen levels. Removing the fluid allows the lung to expand, making breathing easier. Pleural effusions caused by congestive heart failure are treated with diuretics, water pills, and other medications that treat heart failure. Pleural effusions caused by infection are treated with appropriate antibiotics. In people with cancer or infections, the effusion is often treated by using a chest tube for several days to drain the fluid. Small tubes can be left in the pleural cavity for a long time to drain the fluid. Nursing management. One ineffective breathing pattern related to decreased lung expansion, accumulation of liquid, as evidenced by dyspnea, changes in depth of breathing, accessory muscle use. Interventions. Maintain a comfortable position is usually elevated headboard. Given oxygen through a cannula, 8 ml per second. To acute pain related to accumulation of fluid in the pleural space and rubbing of thoracotomy tube to the lungs. Interventions. The presence of pain, the scale and intensity of pain was well assessed. The client taught about pain management and relaxation with distraction. Chest tube secured to restrict movement and avoid irritation. Given prescribed analgesics I.e. diclofenac 75 mg. 3. Risk for nutrition impairment, less than body requirement related to inability to ingest adequate nutrients. Interventions. Patient relative I.e. his father encouraged to give him energy-reaching foodstuff together with energy supplement so that he can get enough energy. Administer DNS as prescribed to the patient to increase energy lost. 4. Risk for fluid volume deficit related to chest tube drainage. Interventions. Encourage the patient to drink enough water to supplement the one lost by chest tube drainage. 4. Fluids and DNS to replace fluid lost in drainage system monitored in 24 hours. 5. Risk for infection related to the presence of fluid in the pleural space and the incision site. Interventions. The patient dressed at the incision site when it is wetted, probably after 2 to 3 days. Given antibiotics as prescribed, i.e. for metronidazole 500 mg 8 hourly, for ceftriaxone 1 gram. Complications. A lung that is surrounded by excess fluid for a long time may be damaged. Pleural fluid that becomes infected may turn into an abscess, called an empyema, which will need to be drained with a chest tube. Pneumothorax, air in the chest cavity, can be a complication of the thoracentesis procedure.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.